Properly, and you can see
Yes,
my
all good.
normal view, not presenter view.
Yeah, great.
Super. Yep. So, oh, sorry, this one's going to keep going forwards. Okay. So, hi everybody. I'm going to talk a bit about artificial intelligence in healthcare. So, I'll just talk a bit about what artificial intelligence is to start with, and a couple of projects that we've done in AI in Kenya, and there's one in Vietnam. And let me just pause that. And then talk a little bit about potential for new AI systems for global health, and hopefully that can stimulate a bit of discussion for the discussion section of this webinar. So, what is artificial intelligence? So, the first time the term came about was in the 1950s, and there was a kind of seminar at Dartmouth College, and a group of experts in computers and information theory all got together to think about how you could use computers to do what the human mind does. So computers were kind of just starting to get to be more useful, and so they wanted to try and figure out, could we make computers do the kind of things that the human mind can do? So can computers learn, and can they do any other feature of intelligence? They said in their kind of proposal, and they said that they'd work this out over 2 months with 10 people working on it, and they were going to call it artificial intelligence. So that's where the word came from. And it's a bit of a funny word, I think. Um, so we know what intelligence is because we have it kind of in our brains, and that's what we do. But what is artificial intelligence? Is it just pretending to be intelligent, like artificial snow is pretending to be snow, or artificial leather is pretending to be leather? Or are we creating actual real intelligence? So that's maybe something to think about. Let's move on. So initially, AI was what's called good old-fashioned AI. Let me see if I can stop this going forward. I don't think I can. And or GoFi, and this was basically what we talk about when we talk about expert systems. And many applications that you see in healthcare are actually good old-fashioned AI. They're not more advanced AI. Um, and so they're basically if-then sequences, or kind of a bit like decision trees. So if this, then we do that. So if a high blood pressure, then take antihypertensives, that kind of thing. And the NHS 111 online service uses this kind of system, expert system, so designed by clinicians, and it's kind of an algorithm that human beings can kind of work their way through. And you can even use a computed version of it online. Quite widely used in healthcare now, so a lot of electronic systems. So if you're prescribing a drug, for example, it might use a symbolic AI or expert system to work out your drug interactions and symptom checkers, and also other types of clinical decision support systems. But what we really mean by AI, when most people are talking about it nowadays, is not really that. That's more just like a normal computer system. What we talk about when what we think about when we talk about machine learning is getting computers to learn how to create these algorithms. So instead of experts sitting down and talking with the computer programmers, we want the computers themselves to be able to create these algorithms that can do things that are useful. So there's several types of machine learning, and I'll just go through some of them so that you've kind of heard of them. You might have supervised learning, and that's where you have training data with the correct answers. So that example of that might be you've got a big data set of um, X-rays, and they've already been interpreted by radiologists, and you've got the radiologist report to go with it. So you can then use that data for training a machine learning algorithm to look at X-rays and work out what's wrong with it. Um, we can do regression, which is the same as what you do in statistics, where you get kind of a scatter plot and you draw a line of best fit. And that enables you to make predictions for data that you haven't collected. So, say you had 100 data points, there's going to be lots of other data points that you could potentially be interested in. And regression will enable you to kind of work out prediction a kind of numerical prediction. We can also use machine learning for classification, so true or false. Do they have a disease or don't they have a disease? The other type of machine learning you can have is unsupervised learning, where you just give the computer lots of data, but you don't tell it any of the answers. But it can still learn things about the data, so it can find clusters in the data, for example. And also, you can use machine learning to generate new data, and we've seen that with images, but also generative AI is what we talk about with large language models, which I'll get to in a moment. Um, and then reinforcement learning, which is another type of AI system, which is like the best example for that, I think, is learning to land a spaceship. So when you are going to fire your thrusters left and right based on kind of wind or the direction you're going in, and through lots of simulations or lots of experiments. The machine learning algorithm can work out a policy for telling you when you should fire your thrusters in order to land your spaceship properly. So this is just a kind of example of regression. So regression comes from the phrase regression to mediocrity, or we now talk about regression to the mean, which is when you see a data point that's an outlier, you're likely to, if it's a high outlier, you're likely to get a lower value with your next data point. And really, it's a line of best fit, and it can be a straight line or it can be a curvy line. But basically, you're trying to predict a value based on an input variable. And with traditional statistics, we can do this as we've got a limited number of data points. But as you get more and more data, machine learning, where you kind of guess, you start off with a guess of your line of best fit, and then you gradually increase the accuracy of it. That is easier to do as we get more computer power. So when computers were very expensive and didn't couldn't handle much data, you could just use a traditional statistical approach. But as you get more and more data, you use machine learning and using a process called gradient descent. So gradient descent is basically where you take the overall error of all of these points, and then you try and get less and less error as your line goes through them. And using a process of gradient descent, you can figure out where you get to the point of the least amount of error. And this gradient descent is used not just for these kind of simple models where you're trying to find this line of best fit, but can also be used for quite complicated models with lots of data points, and is a widely used way of working out what the best function is in machine learning. So basically, gradient descent uses calculus to work out what the gradient is, and then we'll step down for the next lot of guesses in the right direction because it's worked out the gradient. And this can be done in two dimensions, like I was just showing, or as you add more dimensions. If you say you have three input variables, you can draw a three-dimensional landscape, and you kind of walk down the landscape with the gradient descent. But then as you get more and more parameters for a model, it gets more and more complicated and impossible to visualize, but you can still use the same calculus to calculate the gradient, so you can know which direction, how big the steps you need to make in which direction to get to the line of best fit. So the line can also be a sigmoid line, which enables you to do classification. So if all your data points are either true or false, you can still draw a line of best fit through them, but it just is a regression curve, and this is another widely used algorithm in machine learning. You can also use gradient descent and other methods for creating decision trees, which then look like those expert systems. Clustering is one of these unsupervised machine learning techniques. So you have data points that are clustered, and the machine learning starts off with guessing where the clusters are, and then using an iterative process works out where the kind of centers of the clusters are, and enables you to find the clusters. Generative modeling I talked about is about creating new data based on lots of samples. Was kind of first popularized with creating images, but now we know from large language models. And reinforcement learning, I mentioned a minute ago about using machine learning to help guide a policy that can determine what something can do. And it's used in things like robotics and landing rockets is the classic example. So all of that machine learning has been creating lots and lots of useful applications in healthcare, and there's actually thousands of healthcare products on the market using those kind of basic techniques. But in the 2010s, there was a renewed interest in AI because deep learning was starting to become more popular. So deep learning uses artificial neural nets. So the ideas with the original symbolic learning was that you can kind of manually create an intelligence. But with deep learning, it was kind of rethinking things and saying, we already have a good example of how intelligence works. It's the neural networks in our brains. Can we create artificial neural networks to try and do these? And so this is basically using the same techniques that we've used before of regression and um, um, gradient descent, and can use supervised or unsupervised data, but uses a neural net structure in order to enable the algorithms you create to have lots and lots of parameters. And with things like large language models, you end up with having billions of nodes in these networks, which enables you to create these predictive models with billions of parameters. Um, Quite often you'll see like an AI in healthcare, and they're talking about using deep learning and neural nets and things, but they are using really what it comes down to is an expert system. So the expert system designed by clinicians, which is a kind of safe and predictable way of doing things, and then you use a slightly more kind of um, uh, like a deep learning type system for doing things like recognizing the language and the questions that you're putting in. So this is an example of an app that was popular a little while ago called Babylon Health, and they used machine learning, deep neural networks for working out what you're asking. And then once it's worked that out, then it plugs it into a normal kind of good old-fashioned AI expert system. We've had a project in Kenya with the Department of Engineering Science at Oxford, which is using some of their technology they developed for monitoring newborn babies in the hospitals in the NHS. And there they were using cameras to watch the babies to detect their heart rate and breathing rate kind of from a distance because you don't want to stick sensors on newborns because especially if they're preterm because they might have quite thin skin. And then they can use the flushing of the skin or changes in the video and changes in how the chest's moving to work out the breathing rate and the heart rate. And then we've been looking at trying to do this to help diagnose, differentiate between severe and non-severe pneumonia, but using a smartphone camera. And so we've been working in Kenya trying to do that. We also had a project in Vietnam, which ran over 4 or 5 years. And this involved lots of different universities all developing clever new AI technologies with the aim of helping healthcare workers in intensive care units in Southeast Asia look after patients. And the idea here really was it's very expensive to just import already established technologies um, um, and then implement them in ICUs when new technologies such as lower cost sensors, if combined with AI systems, could potentially achieve a similar type of thing if they're co-designed well with the healthcare workers who work them and really meet the needs of those healthcare workers. So that project's called Vital, and there's been quite a few publications from Vital, so you can have a look at those, and maybe we could circulate some afterwards. And then finally, just wanted to talk a little bit about AI scribes and the use of large language models. So, although there's been, like I've said, lots and lots of AI been developed in healthcare over the last 20 years or so, and actually most kind of digital radiology systems, digital pathology systems, and things use AI to some degree to help the clinicians working. There's been a massive takeoff recently in large language models used in healthcare, and this is primarily for note taking. So doctors, this is kind of how it works. So a doctor will use their smartphone or an app that runs in their browser, listen to it'll get it to start recording, it'll listen to the consultation, create a transcript of that audio that it's listened to, and then use a large language model to turn that transcript into a summary that can then be cut and pasted into the patient's notes. And there's quite a few companies doing this now and quite widespread adoption. So here in New Zealand, it's something like 50% of GPs are using it. And in the UK, there's lots of GPs using this, and it's been rolled out in places like Kaiser Permanente. This is a survey from a little while ago now of GPs using it. 20% reported using generative AI in clinical practice, and most were using it for generating documentation after patient appointments. So how's this all come about? So we've had transcribing in healthcare for a long time, like Dragon Naturally Speaking, but it is quite expensive and it doesn't produce this summary, which is the useful bit of information. So you just get your kind of transcript, which is too long normally and then you'd have to spend a long time editing it down. And the reason we've got it is because, as you all know, ChatGPT was released and showed that large language models could work and could be used to create summaries of medical notes. So how does a large language model work? So they use these deep learning neural networks that I was talking about, developed by people like Jeff Hinton, Ilya Sutskever, and others. If you think about it like a giant model, which you can kind of show in an equation, it converts the input text into numbers. So each kind of word or token, which might be a word or part of a word, is turned into a number called an embedding. Those numbers are then fed into this enormous equation, and basically what the equation does is it uses all of these neural nets to multiply weights and add them all up, and eventually you get this kind of massive multiplication and addition equation that then produces a number at the end of it, based on all of the numbers from the coded text that goes into it. And then that number that comes out of it then can be coded back into a word. And so therefore you can use this model to predict the next word in a sentence. AI research don't know exactly what the weights in the models represent. So you create a large language model by gathering lots of training data. So you just want a lot of text, basically. So people like OpenAI, they downloaded all of the ebooks they could find. They downloaded Wikipedia. They scraped news websites. And then they would sample sentences or bits of sentences or bits of text out of this, give it the first kind of 10 words or so, and then say, can you guess what the next word is going to be? And if it got it right, then that reinforces the network. And you basically do this billions and millions of times, and you build a network that's capable of accurately predicting the next word in a sentence. When they built ChatGPT, they introduced reinforcement learning with human feedback so that they could find out whether or not the text that was being produced was accurate for things like asking questions. And then this also then feeds back into the model to try and improve it. There's two kind of things to think about with large language models. One is what's called bias and one's called variance. These are common problems with machine learning. So having high bias means that you've underfitted the model. So you've drawn like a flat line when you should have drawn a curve. And overfitting is when you've drawn too curvy a line, you tried to go through too many data points because you've got too many parameters in your model. And that's called high variance. And normally either of those is bad, and you kind of try and balance them to get an accurate model that can make good predictions. But there's a nice video on YouTube of Andrej Karpathy, who is one of the OpenAI and also worked at Tesla. He's a AI engineer, quite a famous person. And he shows that if you turn down the randomness of these large language models and just copy and paste in the beginnings of Wikipedia articles, it will just predict the exact next word in the Wikipedia article and just kind of recreate the whole article. So what's probably happened with large language models is that they've overfitted and memorized all of the text. So when you're asking a question in a chat GPT or something, it's pulling text out from some bit of text that it found somewhere on the internet. What they hoped was that this, they called this double descent, and this is from a blog post on OpenAI's website. After it's memorized the entire of all the text, you can then get decreasing error as you start to develop new kind of abilities within the model. And they hope that as they increase the model size, it'll get better and better at that. But there's a kind of rule of diminishing returns with that, and it gets more and more difficult to improve the quality of the model as you get bigger, but much more expensive to train. Yep. So I think I'll probably stop there because I think I've almost run out of time. But we can maybe save this for discussion. But there's quite a lot of discussion about whether large language models should be used for summarizing text or used in healthcare in general, just because of the way that they've been designed. And maybe we can have some questions on that at the end. Um, one thing's for sure, and that's predicting the future is hard. Elon Musk, one of the founders of OpenAI, said in 2015 self-driving cars will be here in 2 years. And in 2016, Jeff Hinton, who's that guy who invented deep learning, he said that radiologists would be obsolete in 5 years. But in modern day, we've still got radiologists driving to work in regular cars. So maybe we shouldn't take these kind of predictions too seriously. There's probably are limits to what we can do with AI at the moment, and something to think about. But we do need to ensure that it's safe and effective, and there's lots of discussions and regulations kind of in train at the moment. The UK a couple of weeks ago just said that if you're using AI for summarization, so you can do the transcription summarization, it probably is a medical device and should be regulated as a medical device. But most digital health technology doesn't need to be clinically validated or regulated like medical devices or drugs. But some of it does. When you're using it for important clinical decisions, it does. Large language models have this problem of kind of inventing text and shouldn't be used just purely for clinical decision making at the moment. But we need to do some more research and see whether that's going to work out in the future as these models improve. And if AI, even if AI is proven to be safe in the lab, the models are shown to be highly accurate, we still need to make sure that they work when humans are using them. Okay, I'll finish there and hand over to Pratap.
Great. Thank you so much, Chris. Pratap,
Let me
over to
stop
you.
sharing.
Yeah, thank you, Chris. Just a second. I'm also facing similar issues to what Chris seemed to have in the beginning. Let's see if I can share my screen effectively. Hmm. Uh,
It should be at the bottom.
it is. No, I just changed computers. So, it's not going to let me do this unless I quit Zoom. So if you don't mind, I'll be back in 2 minutes. I'll get my other computer and fire
You
that
just
up.
want to send it to me. You can send it to me and I can share
All right,
it.
that's a good idea. Yeah.
That's
I'll
might be easier.
Maybe I could take a
Everyone, while
question or
we're
two if
doing
anyone's
this,
got
if
any.
you want to start thinking about questions.
Elvin, I'm sure you've got a question.
Yeah, I do. I was looking for the hand up, and that's maybe I can just say it. I'm curious. I feel like a lot of people talk about putting AI models into production, but a little bit less so about how to kind of surveil some of these models. after they've been deployed. I was wondering if you had any general thoughts on how we should better do post-market surveillance and if there are any examples of people doing this.
Yeah, so there's been so the FDA have done some work on that. There's a document I can circulate actually where they talk about the need for as if because a lot of AI systems are designed like large language models, they just were trained once and then put into practice, and they're not updated. They get updated every few years or something. But a lot of AI is supposed to be run is continuously updating using the new data that comes to get better and better kind of as they run. So obviously, if you did a trial of it at one point and then it gets used and gets loads of data and changes, then is the trial going to be valid after that point? And so it is quite a problem. And it kind of strikes at why we need a different kind of regulation for AI systems. And I think everyone's kind of getting on board with that now. So initially it was let's just treat these like they're medical devices. But now it's we really need to think hard about how we're going to do it. They're going to be an important part of healthcare, so probably need to not just think of them as medical devices and regulate them kind of appropriately. Cool.
Thank
I think we look like we've got Pratap's presentation ready to go, so I hand over to him.
Thanks. I think it's not in full screen, which I don't exactly know how to do, but I think it's okay.
Yeah, maybe should be okay. Might be able to take off the side banner by clicking on the left arrow in the bottom left of your screen, so you can have as much of the screen as possible. So yeah, great. Um, yeah, thank you everyone. And sorry, rookie mistake. I got a new computer and didn't set up all the permissions for Zoom to share my screen. Anyway, so it's here now, and my name is Pratap. I believe many of you know me. It's nice to see old friends and colleagues in the audience as well. And I'm going to keep this broadly, uh, take a different approach to Chris with AI and global health and try to keep this both personal and practical. Um, and talk maybe touch more upon the implementation and business models and the practical aspects of getting AI into global health settings. So, as you know, my name is Pratap. I'm at the Global Business School of Health for Health at UCL. I have been working in Kenya at Strathmore University Business School for about 15 years almost now, and also have a social enterprise, HealthyNet, in Kenya, where we've developed and deployed technologies in global health. So next slide, please, Catherine. Thank you. So I thought I'll start the story. It's a little old. So this is my wife getting an ultrasound during COVID in mid to late 2021, so almost 4 years ago now. And Elsie is the nurse who is conducting the ultrasound using a point of care ultrasound probe that by now everyone is familiar with, and looking at the scan on a tablet. And this is particular pertinent for me, especially because this is my wife and unborn child then getting the benefit of a scan and technology that we had developed at HealthyNet to enable this kind of service at the point of care. And yeah, one of the interesting things is that Elsie was the first person and only person to know that what kind of baby we were having, a boy or girl, until she was born. And that is pertinent for a little later in the talk. So anyway, the point of this picture and slide is that the journey of AI and how it's deployed is quite personal and is going to touch all of us, as many of you have already experienced. But it's how it is going to end up touching and having an impact that I think is especially important. Next slide, please. So the ultrasound example is important because in high income settings, whether in a country like the UK or in Kenya, we take ultrasound for granted. But the actual access to ultrasound scans in pregnancy is still very limited. We don't have the exact figures, but what we've estimated in Kenya is that less than 5% of pregnancies get a scan in the first or second trimesters of pregnancy. A lot of people do end up getting scans in the third trimester, but an early scan in pregnancy is more relevant and important for the dating of the pregnancy so that we can manage that pregnancy journey and all the other services around pregnancy with um, early estimation of gestational age. And that's why it's important to have a scan early in pregnancy. And the access to to scans in pregnancy is hidden in plain sight, and the lack of access in that picture on the right. So the devices that have been used for scanning, for ultrasound scans until about 10 years ago have been big, large devices like the one in the picture. And the person conducting the scan is highly trained, at least 2 years of training. And that specialist, either a radiologist or an obstetrician, or in Kenya, a clinical officer trained in ultrasound and radiology, that specialist is in short supply. So most of them tend to be in the big cities, um, and very few of them in rural areas where most of the access problem is. And so essentially the problem is that mothers have so far needed to go to the scan rather than the scan being able to go to the mothers, which is a fundamental challenge in increasing access to ultrasound in pregnancy and many other types of services. So next slide, please. So that rise of the handheld device, the point of care ultrasound scanner, has changed a lot of things in the last 10 to 15 years, with companies like Butterfly and many other companies now providing these small handheld devices that now can be taken to conduct the scans in remote areas. As part of this, there are two other shifts. One is task shifting itself, where we can have not only radiologists, gynecologists, and obstetricians, or clinical officers, sonographers um, do those scans, but it could be the skills for scanning could be expanded to a wider pool. And there's a role for AI for image and possibly wider analysis, as we saw from Chris's talk. There's a number of there's been a prediction that radiologists will be obsolete. There's a lot of automated uh, analysis that can be done by AI, um, especially in radiology. But the question broadly is, how do we deliver all this technology to see improvements in maternal and neonatal outcomes, which have stagnated over the last 10 years or so. So there was a lot of improvement, reductions in neonatal and maternal mortality, morbidity, uh, around the time of the Millennium Villages and Millennium Development Goals. But the last 10 years or so have seen relative stagnation of those improvements. So we're a bit stuck in delivering improvements. So let's go to the next slide and see. I'm going to present three broad ways that ultrasound has been tried to try to be implemented in global health settings. So the first one, there's a paper that came out this year early, where it looked at the non-clinician providers, mainly nurse midwives, who have traditionally not been trained to conduct ultrasound scans, but training them and providing these handheld devices to nurses in smaller primary health centers to conduct scans. So I'm going to call this paradigm training because it mainly involves training a large cadre of nurses in this case to conduct point of care ultrasound in their primary healthcare facilities. And this paper looks at all the responses from them about around this technology and how they use clinical decision making, how it improves or impacts quality, the issues around training, the technology itself, and how sustainable it could be. Let's go to the next slide, please. Now, this is the paradigm that we implemented in Kenya starting around 2018, 2019. And this is the paradigm that the first picture of my own child being scanned comes from. So here we trained nurses to conduct these scans um, and implemented this like a distributed Uber-like service. So a trained nurse with a mobile probe and tablet could travel to small sites. This paper that we published last year focuses on the findings in urban slums in Nairobi, but a number of these scans are also conducted in pretty remote sites in health camps where there's no fixed healthcare facility. So where the nurses could travel with a small device and a tablet, essentially technology fitting into their pockets, go into other health camps, sometimes in people's homes, like in my case, but deliver the scans very close to where the mothers actually live. But importantly, those scans, the nurses were taking the images, were trained to take the images, but those images were reviewed by a remote specialist, a sonographer, or an obstetrician or radiologist, who could do this um, in the comfort of their own settings on their own device with minimal technology required. And uh, the paper here talks a little bit about all the different stakeholders in this process and how they experience the technology and the service. Let's go to the next slide. So now this paper from 2022 by from the University of North Carolina, Chapel Hill, and Google Health talks about a slightly different approach, which is called, broadly comes under the idea that you can conduct a blind sweep, meaning that you don't have to see the images of the ultrasound to detect certain parameters that are of importance um, from the fetus, from the pregnancy. So so the paradigm involves 6 sweeps of the abdomen, 3 sweeps vertically and 3 sweeps horizontally, and the video from these sweeps, without having to see uh, any image from the scan at all, can be the artificial intelligence can be trained to detect specific parameters. In this case, detect parameters relevant to fetal age. So the blind sweeps can automatically detect gestational age. And now this technology does not need, it needs very little training. So it needs people to conduct these sweeps, and the device, the smartphone, will test, will run the video from the sweep against the trained AI model and give you the result of the gestational age in this case. Let's go to the next slide. And so I left this table blank broadly to keep this as an open discussion and get people to think about all the different things that are involved in these models and um, how we could think about AI impacting, in this particular example, ultrasound for pregnancy. So what I have filled in is this first row where we talk about and just the provider part. So there are three paradigms that I've taken the liberty to show the contrast. So one is we train existing healthcare providers, mainly nurses, to conduct the scans with some AI in support, uh, potentially, or even without AI. Uh, and that has to be implemented to have the kind of impact that we would want to see. The next paradigm is with telemedicine, where you have um, the minimal training required to generate the images required for ultrasound, which would then be potentially supported by AI, but again, bring down the task and the skill level needed to conduct these scans. And the third paradigm is a blind sweep paradigm, where we see AI in the lead. So we don't need much training, but essentially lay people can conduct these scans to get the relevant parameters detected from the pregnancy using a blind sweep. So the different things that we could imagine or need to think about, whether we use AI in support or in the lead, is going to make a big difference in how these services are going to impact health for millions of people. So each of these paradigms needs some level of training, from conducting pretty much complete scans to just doing a blind sweep. And there needs to be support and supervision, whether this could be with people or AI itself. But the next important step to think about is the business model. So a lot of these technologies require to be implemented in a sustainable way that involves costs of real people, technologies, support, training, and so on. And seeing AI in supportive roles or leading roles makes a big difference to the business model itself. And based on the people involved, the implementation model, the training, support, business model, pricing, there's going to be very different levels of fidelity to intended ways in which these are implemented, the acceptance of these technologies, their use, their actual effectiveness, and cost effectiveness. Then comes the AI model itself. Are we training for a specific parameter from a diagnostic perspective? Like in the blind sweep paradigm, are we training to potentially support people to conduct better scans in a supportive role, for example, get better images or get better video that is going to allow the AI to do a better estimate of different things. So, for example, the way to frame this would be that the blind sweep paradigm for gestational age is training a model for a very specific parameter for gestational age. So you detect, say, a femur length or a head circumference or a few other parameters and train the AI to accurately detect fetal age. But this training and all the data and the parameters need to be generated for every other fetal parameter that you would want to detect. Let's say you want to detect malposition or placenta previa. Uh, the AI needs to be trained for those specific um, goals, and ideally, that AI needs to be deployed in a device, possibly without needing internet, in a very low footprint that can be used in very remote settings. But the supportive AI could be used to train the user to detect, to conduct or gather better data in order for AI models to be doing much more broad assessments on the quality of the scan. So the point being is that what the way we see AI and the role of the AI is going to could be very different and needs to be thought about with a large number of other aspects of how we want the technology to be implemented in health. And this leads to how we want to regulate this technology and the use of AI and ultimately drive the kind of impact we want to see. And the reason I have impact right at the bottom is that, coming to the next slide, please, is that we have seen the impact, both good and bad, with the use of ultrasound in pregnancy. So I try and keep making this point every time to make sure this doesn't get glossed over. Because ultrasound has shaped society and humanity significantly, and it's not very obvious, but in many settings, but in societies where there has been this impact, this is huge. So we know that ultrasound leads to sex-selective abortions in many populations. And the use of ultrasound in the 70s and 80s and 90s has changed the composition of society in a hugely significant way. And now, and the main approach to prevent these unintended consequences has been regulation, that we are regulating mainly the people using these technologies to prevent them from being used for fetal sex determination. But now we're seeing a shift in access where ultrasound devices can be used almost anywhere within the setting of people's homes, just like in my case. And the ability for those regulations to be effective is going to be, yeah, in question is an understatement. So we have to rethink how ultrasound may impact how it is used in practice. So this slide is important to just make sure that we recognize that there are unsolved questions when it comes to the use of technology in health. And as we start moving into this realm of AI for increasing access to ultrasound scans in pregnancy, that there are these issues that we need to grapple with. Let's go to the next slide, please. So getting to the end, so there's a really interesting approach and challenges described in this paper by Eric Topol and colleagues, where they do highlight some of the challenges when it comes to working with AI in global health. And in the bottom row is this challenge that we don't have, the tools that we have so far, for example, with medical scribes and large language models, we have a very specific data set that's going to work with specific problems like summarizing notes, for example. But a large part of medical data is going to be a combination of diverse types of data. So it's going to be screening data, population risk, it's going to be images, it's going to be about medical records in hospitals, outcome data. Coming together of all this data is still a big challenge. It's not only about generating these large and different and diverse data sets, but making use of them in meaningful ways that goes beyond what we see currently with specific data sets around text alone or images alone and so on. There's a lot of challenges with working with real world data that all of you probably are quite familiar with, moving from clinical trials to routine data. And do all this while we focus on actual clinical benefit and meaningful use of AI and technology in health. Let's go to the next slide. So this slide then speaks to what Chris said in his talk about how uh, we train we train these AI models on these larger and larger data sets. And this is an interesting insight into that approach, is that very soon, at least for large language models, there is a limit that we are going to reach with what is the training data and what are we going to use with that data, or what's it going to be used on. So what this slide shows from this paper from Nature is that the size of these data sets, essentially all the text on the web that LLMs are being trained on, is pretty much reaching the size of the entire data that's on the web. And so the quality improvements, like Chris showed, the law of diminishing returns, is going to be pretty strongly felt in the next few years. So we are reaching some of the theoretical limits of what large language models can do. Their applications are going to be really interesting, but I think the power um, of their application is going to lie to some extent in how we can start generating new data and diverse data. So in the next slide, I go back to the pandemic around the time that scan was done on our child. This is the image from the number of people enrolled in clinical trials in late December 2020, uh, which shows you how little data we are generating from, in this case, Africa, and broadly the global south. And this is highlighting the problem that we have, that Eric Topol's paper talked about, that we don't generate enough data, and a lot of this data is unimodal, in this case clinical trial data. And so how do we generate better multimodal and effective data? And I summarize this in the next slide, where I think it's important to think about how we approach AI in global health. So can you go to next slide, please? And so this is my take, bringing together a few points where if we want to generate equitable AI for global health, we need to be responsive to what the needs in the population are, and deliver and generate this AI while delivering services. It's hard to think about this as data capture versus and separating data capture and data use paradigms. We need to think about multimodal data, and we need to be making sure that we are representing the populations that we want